Good afternoon and welcome to Kidney Talks with the GW Ron and Joy Paul Kidney Center, MOTEP, the National Minority Organ, Tissue, and Transplant Education Program, and the Pennsylvania Avenue Baptist Church. My name is Jennifer Arrigo with the GW Ron and Joy Paul Kidney Center, filling in for Reverend Kendra Curry with the Pennsylvania Avenue Baptist Church. It's a pleasure to be here today with you all. Today, our presentation will be on liver transplantation with our special guest presenter, Dr. Stephen Gray, Surgical Director of the Liver Transplantation at the GW Transplant Institute. Dr. Gray is an Associate Professor of Surgery and Surgical Director of GW, the transplant program in liver. He received his medical degree from the University of Michigan and completed his general surgery training and abdominal transplant fellowship at the University of Alabama at Birmingham in 2012. He also holds a Master of Science in Public Health and Clinical Research from the University of Alabama at Birmingham School of Public Health. Prior to joining the GW faculty, he practiced transplant surgery at the University of Alabama at Birmingham and the University of Maryland. He specializes in liver transplantation. From a surgery standpoint, Dr. Gray is involved in the evaluation, management, and treats patients with end-stage liver disease, including management of complications of cirrhosis, management of immunosuppression, and optimization of medical comorbidities. His research interests relate to ensuring the culturally and ethnically appropriate assessment strategies are used to eliminate age and racial health disparities in liver transplant candidates. He has a special interest in the assessment and selection of appropriate older adults for liver transplantation. He also has an interest in health services research, specifically identifying modifiable predictors of transplant outcomes. Our two panelists today are Dr. Joseph Keith Melanson and Dr. Clive Callender. Dr. Melanson is chief of the GW Transplant Institute, medical director for the GW Ron and Joy Paul Kidney Center, and professor of surgery at the George Washington University Hospital. Dr. Melanson's specialties include kidney, liver, and pancreas transplantation and stem cell transplantation, as well as laparoscopic kidney donation. Dr. Melanson is joined by our esteemed panelist, Dr. Clive Callender, who is a current professor of surgery at Howard University College of Medicine. In 1991, Dr. Callender conceptualized and founded National MOTEP for the purpose of increasing minority donation rates nationally. Without further delay, I would like to turn things over to Dr. Gray, who is going to speak with us about this very important topic of liver transplantation. Take it away, Dr. Gray.
Thank you very much for that introduction. Let me go ahead and pull up our slides. So today we're going to talk about liver transplantation, and I think this is also germane to the kidney transplant population or patients with kidney disease, because oftentimes these organs fail and relate to each other. So liver transplantation, there's a transplant pathway which is very similar to the kidney transplant pathway, where there's a role for the transplant center, there's the role of the organ procurement organization or donation, and then there's the role of the greater healthcare system as a whole. And this slide kind of demonstrates that pathway. But before we get started, we have to remember that liver transplant is still a relatively new thing. It's come up within most of our lifetimes. The past 60 years, in 1967, there was no liver transplant. That was when the first one occurred. Dr. Starzl began liver transplant in Colorado, initially transplanting children, and subsequently moved his career to University of Pittsburgh, where he's been most famous and most associated with. Where liver transplants went from something was experimental to now it's the therapy of choice for acute and chronic end-stage liver disease and some of the inborn errors of metabolism. So we transplant people all the way from 6 months old, probably up until their 70s. In the absence of reliable alternative replacement therapy, liver transplant is life-saving. And again, we went from something where his first 3 or 4 patients all died, didn't survive, till now where liver transplants is almost has an expected outcome associated with it, where now we're looking at outcomes of 1-year survival of greater than almost 92%, 30-day survival of 97%, and a 3-year survival of 85%. So we're transplanting people not just to save them in the short term, but transplanting them to live a long and productive life. There oftentimes are young kids who were transplanted who I've even interviewed for positions in med school, for residencies, and also to become transplant surgeons. So there are, this is something that can be both life-saving and life-enhancing, and you can go on to live a very active life following liver transplantation. And we can see here, over time, almost the past 10 years, we've been adding around 10,000 to 12,000 patients to the list each year, only performing around 8,000 liver transplants a year, but still adding these patients to the list. This next slide here really shows where the problem is, in which, and this is for all organs, but there's a significant gap between the number of patients who were listed for organ transplant and the number of patients who are actually getting transplanted. And I think that this is where my next big focus is, which is organ donation. This is the one spot in which we can all affect the organ shortage, is by registering to be a donor. If God forbid something happens to us and we end up in a position where we could potentially be a donor, making sure that we've had that discussion with our families, with our loved ones, with the state. When you go through and you renew your driver's license, you can self-designate yourself for donation, and that's probably one of the most important things you can do. And hopefully, you never are in the position where you or a loved one are a donor. But if you are, at least something good can come from it. As one of my mentors said, people have been dying since time began. It's only been the past 50 or 60 years in which something good can come from that death, and you can help somebody else. So here we see this slide, which illustrates how there's a significant differences in where you live in the United States and your likelihood of dying while you're waiting for a liver transplant. The good part is the graph on the right side of the slide, on the left side of the slide, does show you how over time we have seen a decrease in deaths of people on the wait list, but you can still see how really where you live in the United States really affects where your likelihood of dying on the wait list, where people on the coast are dying at a higher rate on the wait list than patients who are living in kind of middle America. And some of that's related to organ availability, and we'll get to that as we keep going through this talk. So, and the question is how should geography impact this? And so the United States, for organ donation purposes, is divided up into 11 regions. And these regions, they kind of make sense, but then they kind of don't make sense. And so, but for years, what we've done is we've kind of restricted organ use to each one of those regions. So the region which I began my career in, which was Region 3, the organs from that region, Louisiana, Arkansas, Mississippi, Alabama, Georgia, and Florida, that's where those organs were preferentially allocated, or they were transplanted. And then, depending on where you're at, there could be higher donation rates or lower donation rates. So, it really makes a difference. It used to really make a difference in where you live. And patients, through advocacy, really ask the transplant community to look at this and to look at ways in which you could affect this and change it to look at broader sharing. And so the thing is what we have to look at was also the effect of the center. So you have, transplant centers aren't the same, just like sports teams aren't all the same. You have aggressive sports teams, you have less aggressive sports teams, you have aggressive transplant centers, and you have some less aggressive transplant centers. And so that you have that effect that's taken into organ donation and organ availability. You also have the cost. You could potentially share organs across the country, but then there's going to be a cost associated with that, with transport of those organs. And finally, you also have the cost in which the patients, which you as the recipient or the loved one of the recipient, which you pay, which is, the longer that organ is outside the body, the longer the organ is associated with what we call cold ischemia time, there's a less likelihood that the organ may work, or there's a more likelihood that it may run into some complications with that organ. So it's all a trade-off. But these are all questions in which, the transplant community and society as a whole, we have to go through and answer. So how are livers allocated, or how do we decide who gets transplanted with a liver with a liver? So since 2002, there's been what's been called the MELD system, or the Model for End-Stage Liver Disease system. And it's a score that's completely objective, made up of sodium, creatinine, the INR, which is a measure of people's clotting factors. I'm sorry, the creatinine, which is a measure of your kidney function, and then the bilirubin. That's basically how this score was. That's all the variables that go into the score. And then it comes up with a mathematical formula, and it gives you a score anywhere from 6 to 40. The patient's actual condition, whether they have ascites, fluid on the belly, encephalopathy, they're not thinking straight because their liver's not working, if they've had infections in their abdomen, if they've been admitted to the hospital with bleeding, if they've been admitted to the hospital, those things do not affect the score currently. Additionally, within blood group, and then livers are divided up based upon blood groups, and the score would be utilized to rank people within the within that blood group. But you can see here of the map of the United States, and this data just was published around the beginning of this month. You can see how, depending on where you're at, you had to be sicker. So the darker the kind of the purple gets, that's the higher your liver sickness score had to be in order to be allocated a liver for transplant. And again, you can see the same thing that kind of, if you can remember back to the slide with mortality on it, there is the same pattern where patients on the coast, California, New York, much of the northeastern United States, are being transplanted at a higher score. So like we just said, how this is a kind of a screenshot of what it looks like in the computer system of how a matched run would look. But within blood groups, the patients with higher MELD score would get transplanted first. And then ties in this MELD score for liver transplant would be broken based upon waiting time on the list. Well, in 1998, the government, we're here in DC, so we have a lot of government regulations. The government came out with what's called the final rule, which is kind of crazy to me because the final rule keeps getting updated. So it's really not the final rule, but this is the most current version of the final rule. And what it says is how allocation should not be based upon the candidate's place of residence or place of listing, except to the extent that it's required to by these other paragraphs, which are basically saying medical necessity and and just the practicality of sharing organs. And so people really looked at that, and again, we keep looking at allocation because it's a line, and nobody likes people who cut in line, and nobody likes it when you feel that you're being cheated. Like I was telling somebody this morning at the gym, I was like, it's kind of like when you buy a car or you pay your taxes, you're always convinced that somebody else is getting a better deal than what you are. And that's what I think the important thing when it comes to organ allocation is it's a transparent system. Although although when you have these high profile people here like Steve Jobs or Mickey Mantle get transplanted, people question it. The system has proven to be fair and based upon objective candidate assessment. But one of the things is like all of us on this call, you can see how depending on where you live at in the country, you could get transplanted at a different rate. So if you happen to be blessed to live in in the South where there's a lot of organ availability and patients are getting transplanted at a lower rate, then things were good. But if you happen to live in California or in Boston or New York City, where people are getting transplanted with a median MELD at transplant of 33, according to that latest data, that's a problem. You're getting significantly sicker. So what happens is this paper, which was published out of one of the Harvard system hospitals, showed that patients according to the system, patients can be listed at more than one center. And so patients were migrating to areas of the country where there was a higher availability of organs. So specifically, you see 31 patients left Boston to go down to the south, to the deep south, to get transplanted. But what they found is, as you can imagine, majority of these patients who were listed, it's a minority of the patients who were in Boston who obviously who moved, but the majority of them were white, older, had private insurance, and had higher education levels, and concurrently also higher socioeconomic status. They did well post-transplant, but really where they lived and their ability to afford, the best care possible and to afford the advocacy of a family who was able to move them across the country for 3 to 6 months, that allowed them to get transplanted sooner and allowed them to live. So how do we look at this? Should we be listing people should organ allocation be just blown up, and should everyone just be listed on one list? One of the things that I found going through and looking at this issue myself was how in 1994, so almost 30 years ago, there was a survey that came out where they looked at recipients and members of the general public. And, despite what some of us as transplant professionals thought, with local organs should stay local, because, that's where the donors happen. That's where the recipients happen. If the donors know that they're helping their neighbor, maybe that's going to increase their amount of donation. Well, the survey, when we asked the public, they gave the lowest priority in the whole allocation scheme to keeping organs local. In fact, they said 2/3 of the general public indicate they'd be more strongly influenced to donate if organs were allocated or distributed based upon a national system rather than a local system. So they've spoken, and it's only taken almost 30 years for us to get to broader sharing and close to this ideal of nationwide sharing. And I can tell you, even my views of this have changed. As somebody who used to practice medicine in the Deep South, I felt very strongly that they're still our organs were being moved across the country to the detriment of our patients. But you can see here what our patients really believe, or the donor families really believed in sharing the organ on a national basis. And so this doesn't project as well as I thought it would, but this is a map here kind of showing what the current system is. So the current system is based upon concentric circles around a transplant hospital. So this red dot in the middle kind of shows you GW hospital. And so for every change in color as you go out from GW hospital, that's how the organs are allocated. So first 150 nautical miles, then subsequently out to 250 nautical miles, and out to the maximum distance of 500 nautical miles. That's how organs are being allocated. And most recently, every 6 months they come out with a new median melded transplant, or the average melded transplant that each one of the transplant centers in the country they can see, and you can really see how this system's been in effect for around 18 months or maybe a little bit longer, how there really, though, has been a decrease in the discrepancy between the highest meld people getting transplanted and the lowest meld people getting transplanted on a nationwide level. So, it's not perfect, but it has gotten better. So again, back to this slide showing you, organ allocation, transplant center, and then also the kind of patient level effects in the transplant pathway. So next, we're going to talk about the wait list and what happens on the wait list. So this is going kind of towards the patient side of it. The importance of you going to a primary care physician who recognizes that you have liver disease and then plugs you into the system and makes that next referral in order to get you evaluated, or get your loved one evaluated for transplant. So this, again, is from this most recent OPTN SRTR data that came out earlier this month, looking at who's listed for transplant. And so you can see over time, the majority of patients listed for transplant are Caucasian. And we can see here, African Americans are here with the triangle. The Hispanics are here around 20% of the list. You can see how patients are on the list. And what we've found is once patients are on the list, they do well from a transplant standpoint. Minorities get transplanted at similar rates once they're on the list. The problem is how African Americans make up around 20% of the population. Liver disease is probably overrepresented in the African American patient population, but we're around 10% of the patients listed for transplant. So what's happening is there's a problem, or there's a discrepancy at the level of the pre-transplant evaluation level with the ability to get referred into a transplant center for that evaluation. And then, also, looking at over time, what we're seeing is that patients are being are getting older that were transplanting. I can remember when I first finished my fellowship, 60 or 61, we really hemmed and hawed about listing that patient for transplant. Whereas now it's like in the mid 70s is when we start to really, really put people through the ringer and make sure that they're, that their heart's really good and, that they're functional and all the rest of that before transplant. But what you can see is how patients live a fairly long time post liver transplant. So this is survival by age, and even the 65-year-olds are getting survival out greater than 70% at 5 years post transplant. So there's a huge benefit to transplanting people who can tolerate the operation for their survival, and then also when it comes to them getting back to the highest quality of life also. So what I wanted to look at is, with this aging of the transplant population, and there's no consensus for transplant. So you already have a patient population, the older patient population, who there's some disparities with their access, and then also you also throw on to that the African American patient population where there's disparities to access. Was there a was that effect additive for transplant? So this is a paper that we published back in 2019, looking at this again. And this was while I was at when I was practicing at UAB, where 14% of the liver transplant referrals are for African American, but the hospital served a population was 25% African American. So there's obviously a disparity in the access to transplant, despite our efforts to do outreach. I think that this disparity is probably multifactorial, right? It's multifactorial from the standpoint that it's patients. Patients will self-select themselves and say that they are not a candidate for something, how I'm too sick, or they would never transplant me, and they don't even go to see their doctor or allow their doctor to refer them. You have doctors whose doctors their views, how they look at the patient, that affects their ability to get referred in for transplant. And then finally, you have the systemic issues whether it is how far they're away from the hospital, whether it's insurance status, all those things definitely affect patients' access to transplant. And I don't want this to be something where people everybody can get transplanted, and that's not true. There are going to be patients who aren't sick enough who are too sick to get transplanted. There's the organ shortage, but everybody can get at least evaluated and seen by a hepatologist and at least access to a transplant evaluation, because studies have shown that even just getting evaluated and being seen and plugged into the transplant hospital, and with all the resources that the transplant hospital has, that actually can increase your lifespan and increase your quality of life. So what we found, so the aim of our study was to evaluate the impact of age and race on transplantation, mortality, and wait list removal. So the three outcomes we were looking at was your likelihood to get transplanted, your likelihood to die, and then your likelihood to get removed from the list. And what we found, and we looked at adult, white, and African American liver-only transplant waitlist candidates who were on this list from 2003 to 2015. In total, we had a little bit over 100,000 liver transplant candidates, and you can see the breakdown of those, where the majority were Caucasian. There was a minority, around 8%, who were younger African Americans, and around 2.5% of this patient population was older African Americans. And what we found I just said, was a disproportionately lower percentage of liver transplant waitlist candidates were African American, despite this historically high end-stage liver disease burden. There's a higher proportion of African American patients were hospitalized at the time of listing. And at the time of listing, the African Americans often had higher scores, meaning how they were sicker. Now, with liver as opposed to kidney, being sicker at the time of transplant does not penalize you, because it's not based upon wait time. It's based upon liver transplants sickest first. Older liver transplant patients, both white and black, had a lower incidence of transplantation than younger adults. Older African Americans were less likely to get transplanted than older whites. And compared with younger white counterparts, both older whites and older African Americans were more likely to be delisted, and that delisting was likely to be a terminal event, meaning how once they were delisted, they died. There was no difference, though, in waitlist outcomes for younger African Americans compared with younger whites. So I think there's a number of things that you could tease out from this. One of the things which we try to tease out was, how sick were the African Americans when they were being put on the list? But but due to the small numbers, those were things we couldn't necessarily get at. But again, I think that once people are on the list and they have access to be transplanted, they can do well. So we've talked about this aspect of it. The other aspect of this referral pattern gets to some of the gets to one of the bigger indications for liver transplant now. So we think the disparities or deficiencies at the referral level may lead to worsening disparities. And so there's a study in the VA, and the VA is a nice population because it takes insurance out. Now the VA has some other issues in that it's a predominantly male population, it's a predominantly Caucasian population, but it takes out the insurance status because everyone in the VA has the same insurance. So what they found was how in this VA study, how only 21 liver transplant was mentioned in 21% of the patients who met the guidelines to be referred to for transplant. And they found that there were significant independent determinants of being evaluated for transplant. And those were being older, having used alcohol, and then also being African American. And when they went through the charts, the active alcohol use was the most commonly documented or inferred contraindication for transplant. Now, we all want our transplant recipients to do well, and we want to select the right people, but we have to remember alcohol use is modifiable. We can put people through behavioral change, social work. We can do a number of things in order to try to get people to stop drinking. And the question is this something where the societal views and providers' views towards alcohol and towards the fact how their liver disease was due to something that they had a role in causing? Is that what's caused them to decide not to send them on to be evaluated for transplant? And then after adjustment for age, alcoholic liver disease and hepatitis C patients were, again, also have the fact that they were also less likely to be African American, the ones who are being referred on for transplant. So again, this is another study from Europe where they were looking at this, where they had 433 patients, and 81% of them had alcohol for their indication for transplant, and 21% of those patients were actually were deemed candidates for transplantation. And they found how the things that mattered most was one of the things that drove it the most was prior compliance with the medical system and the physician's empathy. So when you start talking about the physician empathy, the problem is how all of us as physicians are human, and so people who we can relate to oftentimes may get the benefit of the doubt. So the joke was always with the UAB where I used to practice was that if I evaluated a teacher, how we were going to pretty much list that person, because my wife's a teacher and I have a soft spot in my heart for teachers. And it's the same type of thing. Well, if you see somebody in clinic and they remind you of your grandmother, or they remind you of your dad or your mom, you're gonna kind of advocate for that person differently, not because it's the right thing to do, but just because it's human nature, and we all come with our implicit biases. But the biases should not really enter into this transplant population, especially when it comes to an indication for a transplant. And so what we've found is over time, we've started transplanting more and more patients with liver disease due to alcohol. Alcohol is associated with around 22,000 alcohol-related deaths every year, and you have the spectrum of alcoholic liver disease from simple steatosis to alcoholic hepatitis and cirrhosis. And with alcoholic hepatitis, which is like acute inflammation due to alcohol, patients, the mortality rate is somewhere between 30 and 50% at 1 month, and there really are no pharmacologic options that are proven to change that. But if they stop drinking and you transplant them and they don't go back to drinking, patients with alcoholic liver disease can do incredibly well. Unfortunately, the general public and physicians are less likely to advocate for liver transplant for alcoholics. And I think this is for a number of reasons. Within the transplant community, there's always been this suggestion that 6 months, like how you make patients wait 6 months, it's some magical number or test that they're going to do better, that they're not going to go back to drinking. Well, actually, the literature says how it's 2 years of sobriety is really predictive, and even then, 20% of patients go back to drinking, and of that 20%, 10% only go back. Only 10% of them go back to harmful drinking. So the length of abstinence prior to transplant is controversial. And then patients who are transplanted, you can see here how alcoholic liver disease has equivalent 5-year survival, if not better 5-year survival than the other indications for transplant. And then the other thing that introduces a disparity into this is that each transplant center can set its own kind of guidelines for what period of sobriety they need. So, for example, I know transplant centers that required 6 months, and I know transplant centers that required 6 months plus a program, and I know transplant centers that required a year. And so each one of those things that introduces a disparity. If you're the transplant center closest to you, or that your insurance company is sending you to, is that it has one of these rules, especially when that rule is not really based upon great literature or great data. So they've looked at, this is the American Consortium study, but looking at early transplant for patients who come in with the most severe alcoholic liver disease. So severe alcoholic hepatitis has, a high 6-month mortality. Like we talked about, there's no medical therapies shown to benefit the long-term survival. And historically, these patients had not been transplant candidates. But if you transplant them, the 3-year survival is around 84% with pre-transplant diagnosed severe alcoholic liver disease. And sustained alcohol use after transplant was around 11%. And of that, the harmful use was even less. You can see here how in 1 year, 94% of the patients without a defined sobriety period were alive, and at 3 years, 84%. And then at 1 year, only 10% of those people were back to drinking, and at 3 years, it creeped up to 17%, which makes sense to a certain extent, because as you're feeling better, you start to feel that you're invincible again, and so you start back to doing things. As one of my former partners used to say, we can fix the end-stage liver part of your alcoholic liver disease. We can't fix the brain part of it, and that's where it's really important to plug people in with addiction specialists and all the the community to help them to maintain their sobriety. So UNOS, our United Network for Organ Sharing, that kind of oversees transplant programs, they did an analysis and found similar post-transplant survival with and without the 6 months without the 6 month sobriety. The similar study was repeated in Europe, and they found that early transplant was life savings in patients who didn't respond to steroids, which is really the only drug therapy for alcoholic liver disease. Around 25% of transplant centers have performed a liver transplant for alcoholic hepatitis. And this is old data because, just like with everything, once you see your friends doing it, your colleagues doing it and being successful, other transplant centers would jump on. In 2014, there were 14 centers who were doing transplants for alcoholic hepatitis. And currently, I think the last time I looked, there was at least 47, and there's probably even more than that. Both the ASLD and EASL both support acute alcoholic hepatitis as an indication for transplant. That doesn't mean you can transplant every alcoholic patient, but that means how once you put them through an evaluation, if they're ready to quit drinking and they're ready to commit to a program, and they have adequate social support, that they probably can be a good candidate for transplant. So again, like I said before, the problem is the general public, and then physicians were less likely to advocate for liver transplant for patients who are alcoholics. And you can see here, this is a picture of Mickey Mantle back when, in an op-ed piece, back when he had his transplant for alcoholic liver disease. So, the thing is how as we know, alcohol is often used as a coping mechanism. So, we really have to, if we're going to commit to transplanting patients with alcoholic liver disease, we have to really commit to addressing these other social factors that can cause them to relapse and cause them to have a poor outcome. So specifically, we have to help with making sure we can try and plug them in with good living arrangements. We have to help them with their comorbid depression and anxiety disorders, and also make sure that we help with the concurrent associated drug addiction that some of these patients present with. Again, it's not the risk adjustment for saying how our outcomes are poor because we transplanted alcoholic. Or we transplanted somebody without insurance. We transplanted, a Black patient population, which traditionally haven't had the same outcomes. To say that and get the risk adjustment so that way people look at your outcomes differently is one thing, but to actually do the thing to modify that potential outcome is really important. And that's, I think, something that we're really trying to focus in on here at George Washington. So, over time, we've seen alcoholic hepatitis increasingly used as a indication for transplant. Alcoholic hepatitis liver transplant recipients traditionally or most recently have been younger, more educated, having more private insurance because it was concentrated at certain centers. So if you knew that your loved one had alcoholic hepatitis and you lived someplace like someplace like we've had patients when I was in Maryland come in from Cleveland who were denied there because they weren't there. Ohio has some more different types of restrictive rules towards transplant for alcohol. So the patients who had funds, they'd shop their loved one around and find a center that was willing to actually look at them. So which again introduces the disparity, because if I have public insurance or if I don't have family who can quit working for 6 months and move across the country with me to take care of me, then that really does change your access to transplant. And this variation, in utilization can lead to disparities in access. So again, like I said, depending with public insurance, depending on where you're at, the government may or may not say what had to occur for you to be able to be listed for transplant. So this slide from a study published in 2019 in the Journal of Hepatology looked at restrictive Medicaid policies when it came to alcohol use. So and what they found in the study was how restrictive Medicaid policies were associated with lower proportions of liver transplants for alcoholic liver disease for patients with public insurance in studies which were in states that were restricted compared to states that were unrestricted. Restrictive policies affected around 68% of liver transplant centers, and transplant rates were 4.7% higher in unrestricted states. And even with the restriction, you had restrictions like in North Carolina, which required a year of sobriety, basically a year of sobriety plus 6 months of an abstinence program, versus other states that just required 6 months of sobriety documented in the chart. And so again, that introduces a significant disparity in your ability to get transplanted, especially if you have public insurance. So, you had some places, like I said, with a 6 month rule, some places required a program. In lower socioeconomic groups with alcoholic liver disease, you found with alcoholic liver disease as a primary diagnosis, patients without college education and non-private medical insurance were less likely to be listed for liver transplant than patients without these things. So again, this is something that, a disparity which we as a transplant community and we as a society need to figure out, so that way patients, again, this is the rule, this is what we're going to adhere to, and how are we going to make sure that everyone is playing on the same field and has the same access to transplantation. So again, back to our slide with the transplant pathway, the last thing we're going to touch base on is organ donation. So here you can see over time, over the past 12-ish years or so, we've seen an increase in donation. I think that's been because, a lot of public campaigns, really advocating for transplant, a lot of commercials, a lot of work by the OPOs trying to get people to have that discussion about organ donation. And unfortunately, you still see this gap between organs that are recovered, though, and organs that are transplanted. And this can be because, it can be for a number of reasons. Usually the reason is that the organ, once you actually go and look at it, and you biopsy it, the organ may not be suitable for transplant. But I think that the key is the more we evaluate organs, the more donors we potentially have, the more likely we are to find organs that are transplantable and be able to help people. Because even if one donor, we always like to talk about the maximum number of organs you can get from a donor, but even if that one donor just provides one organ, that's still one person who is going to potentially live. So it's really important, just to have that conversation as far as organ donation. The other thing that we've done over time is we've tried to aggressively go after donors that we potentially in the past hadn't. So these are what we would call the brain dead donors. So these are donors here in green who are being evaluated for transplant or being offered transplant, who no longer have any brain function. They are brain dead donors. They're heart beating donors. That's kind of the gold standard in the donor world. These other donors here, kind of in this brownish orange, what we call donation after cardiac death donors. So this is a donor or somebody who's in the ICU who has a non-survivable brain injury. The family has determined that they're no longer going to. The person would not want to live like this, and they're going to stop the ventilator or turn off the drugs that are helping to keep them alive. But the family wants something good to come out of it, and so this is called donation after cardiac death. And so in that case, they would withdraw care inside the operating room or in a room near the operating room, and then rapidly, once their heart stops, take them into the operating room and rapidly take the organs, recover the organs, and try and use those for transplant. Again, it's all about trying to get more organs into the organ pool to give more access to more patients for transplant. Because there are multiple reasons that you can the indications for transplant, but we don't have organs that are currently, they're not currently on the shelf or being grown in labs to be utilized for transplant. And here you can again see, as we talked about, where the organs are coming from. Areas of the country where you're getting more organs per donor, in the dark, and kind of in this dark purple, and areas of the country where you're getting less organs per donor, kind of in the lighter purple. But again, every organ that we get into the organ pool that can potentially be used for transplant is at least one person who could potentially live and get back to living the life that they wanted. The other area is looking at other ways to expand the donor pool. And I put this slide up because these are kind of probably the three biggest things that have happened in medicine probably in the past 12 months. The first slide here, this is Dr. Montgomery in New York. He did a pig to cadaveric to a cadaveric donor, to a brain dead recipient transplant, because of a proof of concept. This is here at University of Maryland, where they did a pig to heart transplant. Unfortunately, the gentleman did pass recently, but again, from a purely advancing our field and advancing the likelihood of us one day getting to xenotransplantation, that was huge. And this is a picture of my former colleagues down at the University of Alabama, who they did the same thing, and they kept their recipient, who was somebody who wanted to donate their organs, but their organs were not suitable for transplant, but he was able to contribute hugely to the field of transplant by his family allowing him to be a recipient of a pig kidney, placed in the standard fashion, placed with standard immunosuppression. This just came out around a month and a half ago. So again, these are all ways in which we can try to increase the donor pool. Maybe not next week or next year, but hopefully within our lifetime, we're doing this, and we're no longer talking about patients dying waiting on the list for an organ. And lastly, this is a picture of GW. hospital where we have recently got an approval to start our liver transplant program. And with that, I'll open the floor to questions.
Thank you, Dr. Gray. This was an extremely comprehensive presentation. I want to ask the audience members to please feel free to write your questions in the comment section. But I did want to go to Dr. Callender and Dr. Melanson to see if they had any questions or additional comments based on your presentation. Dr. Callender.
Well, I think one of the questions that they asked that you would probably put forth is a very important one. It says, are there formal programs in place to help doctors and or centers to overcome their biases? What's your response to that, Dr. Gray? I think that is the question of the day, because I think we need to know the answer.
Right. I think you're right. I think every transplant center is not like GW, in which all three of the transplant surgeons are African American. That's not the way in which most centers are. I mean, I can remember how excited I was to see Dr. Carlton Young at Alabama and to see Dr. Melanson when I met him years ago at SPAS, and seeing somebody else who was interested in doing very well in the field that I was interested in. I think that there is interest amongst all of the transplant societies in providing a cultural competency education, and so I think that's something that's happened. I think that the MELDS, the nice thing with liver transplant is, it's being done based upon an objective score, the model for end-stage liver disease score, which, no matter who you are, your labs are your labs. So there's really not an aspect of, once you're on the list, where you come up on the list or what order you're in is not an issue based upon who you are. What I think with the disparity, it can really be addressed, though, is in who is being referred to that transplant center, and kind of the first step to be evaluated for transplant.
But I think the answer to the question is there are not formal programs in place to help doctors and our centers to overcome their biases. I think you're right. At GW, we have a unique situation, but across the country, there aren't enough formal programs to help doctors overcome their biases, and we all have biases. Yeah. And so I think that's a question that they've asked that really is important to understand, that really the answer is no.
Right, but I would say I do think that from a transplant community standpoint, people we're at least starting to have the conversations. I know I gave a talk a couple of years ago when I was fellowship director to the fellowship directors about instituting cultural competency into the fellowship program. Now, and I think even within our transplant society, there's the new DEI officer and whatnot, but still, I think it's very much I agree with you, it's the infancy stage, and we really have to, and it can't just be for majority people, it has to be for all of us, because all of us come with biases. And so how do we make sure that we're being objective and at least cognizant of our biases, so that way you can try to counteract that.
It's almost unfair to have that question come up and have Dr. Callender be the person to ask you to explain yourself, because Dr. Callender is probably uniquely qualified to talk about how long you have to fight to have things change. In kidney transplantation, he started his fight decades ago, and we're just starting to see equity in the way deceased donor kidneys are allocated. So we've come a long way in kidney transplantation, and obviously we have a long way to go in liver transplantation. And the issue is, because Stephen, you're right about the MELD score and such, but as long as there's any subjectivity, there's going to be biases that creep in. And I think that's the answer to the question. There's still subjectivity at these programs. And if we thought that, as a country, that we had moved beyond seeing race or seeing color, all we have to do is look at this very objective process that's going on not that far from here for this great friend of mine, Ketanji Brown Jackson, and realize that somehow the questions are being asked of her in a very different manner than they have of other people that have been confirmed to the Supreme Court. So we still have a problem in this country. And I love your euphemism, Stephen, but it's racism. Like you said, the problem is multifactorial, but one of the big factors is racism. And we need to just call it out. Now, I agree with you that we are addressing it, and it will be addressed. And I know we're addressing it here at our program. But I think the answer becomes, as we start to move away from these biases, how do we, in a very academic way, how can we call out our colleagues? Because, no one wants to be called a racist. And it doesn't mean that these people are out and out Klans members, but it does mean that there are biases. Right now, because like you said earlier, we're about 11, African Americans make up only about 11-12% of the population. In kidney disease, we're about 33-34% of end-stage renal disease. We are getting now, because of the work of people like Dr. Callender, and also someone else you mentioned, Dr. Tom Starzl. Tom Starzl was a huge advocate for minority access to transplantation. And so those things changed over time. And now African Americans that only make up about 11% of the population get an equitable amount of kidney transplants because of a lot of changes that had to occur. And we really just got over that hump in 2014. Right now with liver transplantation, you're not seeing the same correction. And unfortunately, you don't have dialysis with liver transplant. So these people are just dying. So it's an acute need. And the question is, or at least my question for you, because I made a lot of statements, but my question is, how do you get, because I think you're right. It's all about access. I think once you get access, then the MEL score takes over. But how do you get rid of the barriers between I have liver disease, I'm being evaluated by Dr. Gray? Why is that? Where is that barrier? Because I think that, I agree that that's the real impasse. It's before they get to the center. And how do we decrease that? The shortest distance is a straight line. How do we make that line shorter between I have this problem, I see Dr. Gray?
Right. No, I agree with you. I mean, I think that it's obviously, race is a huge issue, and I agree with you that the problem isn't once you're on. I think there are problems once you get on the list, and there are problems once you're at the center. I mean, I'm not naive, but I also think that that the bigger problem is the referral from the community having the patient with liver disease through their primary care physician, through the other parts of the healthcare system and into the transplant center. And I mean, I think it's a number, and you're absolutely right. It's different. With dialysis, you can sit and look. If you go to the dialysis center and you're like, well, a year ago, this dialysis center was 50% black and 50% white, and now it's 75% black and 25% white. Well, where the white people, where did they go? Did they get transplanted? Whereas with liver transplant, they're dead. Trying to figure out the actual number of patients who need a liver transplant is incredibly difficult. And it's the same type of thing. I think you and I have had this conversation, before. As far as some places in the country, they're just not getting referred. And so you have the problem of access. And when I was in the South, I used to think, well, it's easy. You're in the city. You can fix a lot of problems with a bus ticket or Uber or taxi or a metro stop, and you can, but still, if you can't get to if you can't get the referral, the transplant center might as well be halfway across the country. It doesn't matter. So, I mean, I think that those things definitely are effective. I mean, I would hope that, I agree with you. I think that a lot of people in society were expecting, this whole, I was looking back at some, the news, and when Obama got elected, racism doesn't exist. The United States has elected a black president, and then we have the next president, and we've definitely swung the other direction. And I think that that there are always corrections, right? The pendulum swings both ways. But I think, the thing is making sure that we get out and I think educate people as to who needs a liver transplant. I think that some of it's the patient aspect of it, because there's nothing worse than when you see a patient or you hear from a family member about a story about somebody like, if you called me a week ago, we probably could have evaluated them. But then you're like, well, they said how they weren't healthy enough to transplant. And I'm like, members of mine, and I'm like, they were fine. I would have 100%, made a phone call and tried to get them at least evaluated. They were transplantable. But oftentimes we can make those decisions on our ourselves. And I think it's the other thing is your medical home. I think that, you need to make sure that whoever your primary care physician is, that they're an advocate for you, that they are, because they are kind of your key to getting plugged into the system. And I think it's the same thing with kidney disease. It's the same thing with liver disease. You need somebody who is going to advocate for you. It's just like us. I think when you want me to objectively make a decision about about somebody in their candidacy for a transplant, don't let me actually see them. But make me see them on paper. Because once you've seen them in person, you've sat there across from them, you've looked them in the eye, you've shook their hand, you're probably not nearly as objective because you really want to advocate for that person and do anything you can to help them. So I think those are some of the ways which I would say that we fix it. And the other thing is to fix it the way in which you and I have worked to fix it by being out there as physicians in the community, and going to high schools and going to colleges and trying to encourage other African Americans and other minorities to pursue careers in medicine. Because again, going to a doctor who looks like you and lives in your community and is a little bit different than going to a doctor who doesn't. Not that they're not good doctors who are majority, but it's different. And so I think that those are all ways in which we can, it's, just like it's a multi-cause problem, it's a multi-cause solution.
Yeah, I don't want to hog all the time, but I will say a big part of the solution is what you've already done, in the sense that academically this has been a focus of yours. Because you and I both know, we go to these meetings and people will go on and on and on about how do you get more and more and more alcoholics transplanted, including the people that finished their last drink an hour ago. How do you do more and more and more cancer patients, including people that have cancer in every part of the liver? How do you do more and more? So there's all these new people that they want to get into the system that the objective criteria in the past have excluded, but you never see how do we get more and more and more Black people that already meet criteria and that are not being transplanted. But I think what you're doing is exactly the right thing, because when you have the sort of papers that you've written and you go to the meetings and you say, look, this is what I have found. This is a problem that needs to be addressed, and it should be addressed before we come up with new ways of transplanting people that we've not transplanted in the past. We should probably just give Black people access to our current objective way of looking at liver disease and let them get transplanted.
Right. But I think that the other part of that is, is as we try to get Black people or get any group of people more access to it, making sure that we are also doing the things to make sure they can be successful with that access. Because, as you and I both, you and Dr. Calendar, and I know how you'll have centers, they'll look and they'll show, well, Black recipients don't do as well. Well, or Black organs don't work. Remember this talk about, Black organs don't work as well. And it's like, yeah, but what are you doing to correct that? Like, if they can't get to you in clinic, what are you doing to help them show back up? If they didn't understand how you taught them how to take their medications, or they can't take their medications at that time because they're driving to drop their kids off at school, or they're doing things, then how do you address that problem? Because again, just saying that your outcomes are poor or African-American outcomes are poor and not doing anything to fix it when it's modifiable isn't fair. And that's something I think that we've seen a lot in medicine over time.
I also had to recognize something that you emphasized in your talk. You said that the problem is that many of the Black patients don't even get to the list. And, many years ago, I talked about a green screen. And I'm wondering, is that green screen still applicable? Is that another reason why the Black patients don't have access to get to the waiting list? Because they're dying before they get there? What else can we do to eradicate this green screen?
But I think even the green, the insurance the insurance or the green screen is important. I mean, I think that's something to address. But even when you look in the VA patient population, they're still less likely, and that's a population where they have insurance, they have access.
Yeah.
So again, I think that it kind of goes both ways. And when you looked at it, it was probably the second biggest cause. It was like alcohol, African American, and then probably insurance. And you can stop someone from drinking, and then you can probably get them insurance, but you're still left with the African American, and then you also are left with the interaction between all of those things. So I think there's a number of things that can be done to address it.
Dr. Gray, we have a comment from an attendee that says, I didn't know that you can actually regenerate your liver. Did you want to touch on that at all?
So the liver is a pretty amazing organ. You can actually, theoretically, you can actually take a liver and give it to adults. We've done that before. That hasn't really taken off very much in the United States just because of risk. Until you get to the point of cirrhosis, and cirrhosis is just a fancy term for a scarred liver. The liver can regenerate, but oftentimes by the time you get to end-stage liver disease, meaning you have liver disease plus like some ascites, which means like fluid around it, or plus confusion, or plus varices, which are blood vessels, that are in your esophagus, that you're throwing up blood over because of. Oftentimes by the time you get to that point, it's no longer is something that can regenerate, but it can definitely grow. Like we do liver resection in a relatively healthy liver, the liver will grow back. It won't like grow back an arm, a whole part of it, but it will increase in function, just like a muscle gets bigger. It will and so it definitely is something that does happen.
Wonderful. The individual that posted that comment said, thank you for elaborating on that. Dr. Callender or Josh Melanson, any further comments before I ask Dr. Gray to just close us out, and then I'll let everybody know we're going to be meeting again for another great conversation.
I see one of the questions in the chat box. I think is a very good question that Dr. Gray should address. Are there any cultural or racial differences in the levels by which the MELD score is determined? Dr. Gray leave?
So unfortunately, Dr. Gray, I think, got kicked out.
Okay. Well, I can answer that then.
Yeah, go ahead.
And the answer is no, there are no cultural or racial differences, although there's been a controversy I think we did tackle it last time about creatinine. Okay, there you are, Dr. Gray. But did you hear my question?
Yeah. So the cultural or racial differences in which the MELD score can be determined.
Yes.
Yeah. It's interesting because it's actually something that it's out for public comment right now from UNOS is to modify the MELD score. They're really, except for maybe like the creatinine change, that's about the only one that's really affected by race or can be affected by race, but it doesn't affect race as much as it affects women. Women oftentimes have a lower creatinine, and the creatinine is a large driver of your MELD score. So for equivalent kidney dysfunction, they can have a lower MELD score because the creatinine doesn't go up as high because of muscle. But I think that, that's the biggest thing. I mean, the good thing is they did take out all the objectivity of what used to be the child score, from back in the 90s, which definitely had things in it that were subjective, whereas this score doesn't. But there still are biases. No score which we ever come is going to be perfect. That'll be my simple answer to it.
Thanks, Dr. Gray. One more question has come in from an audience member. Should you detox your liver? And if so, how often? Were you able to hear that, Dr. Gray, that question?
No, I didn't. What was the last question?
Should you detox your liver, and if so, how often?
I don't necessarily believe in detoxing the liver. I don't know that there's really any approved way to do it. I think that, it's just like everything else. If you are taking care of yourself, meaning minimal, no to moderate, minimal drinking, staying active, eating a healthy diet, trying to maintain weight. That's probably the most important thing, and more important than any, kind of, bottle that you're going to take that says detox on it. I mean, I don't know if Dr. Melanson or Dr. Callender have an opinion on that, but that's just my general opinion. It's like nothing's been proven to work necessarily as a liver detox. Now, what a detox will do is make you lighter by taking money out of your pocket, but it really doesn't do much else besides for that.
Dr. Callender, Dr. Melanson, you want to comment on that?
Well, I think his answer was quite good, except that it kind of brings to mind the reversible and irreversible causes of fatty liver disease, which are maybe what she means to talk about, because I think that those are conditions that are worthy of discussion relative to how do you stay healthy, which is what Dr. Gray answered.
I mean, I think the most important thing is, is trying to, if you're diabetic, trying to control your sugar, trying not to, the cholesterol, all those things, trying to put the best environment, your body in the best environment that you possibly can, and that's harder to do than it is to say, because, because some of those things taste good, but,
Yes, agreed. Any other closing comments, gentlemen, before we wrap it up?
No, I would like to comment on the last thing Dr. Gray said, which is, people tend to love this concept of natural herbs and healthy sort of medicines. Anything that doesn't come with a prescription or is recommended by a doctor seems to be what people latch on to. And I totally agree with Dr. Gray. A lot of this stuff is hocus pocus and doesn't work and can harm you. And just because you're buying something at a health food store or it's natural, quote unquote, doesn't make it any healthier. And, this goes along with this movement in this country, this anti-vaccine movement that has captured so many people, where you have a medication that is proven totally, completely effective and have to jump through all of these regulatory hoops to be approved, and people have a problem with it, but they will take any herb that out of any health food store or naturalist kind of treatment center, and a lot of times these things either don't work or are harmful, and that's, I think, kernels of wisdom that Dr. Gray was trying to impart. So I definitely support that. And I would just say, Dr. Callender has made a lot of his career by just telling people to take better care of themselves. Meditate, exercise, drink more water, get enough sleep, eat healthily, avoid sodium. These are the kinds of things people just want to tune out because it's so old-fashioned and mother wit. But it's good data to back up all those things that Dr. Callender's been talking about for years. So yes, be healthy, pray, take care of yourself. You're going to be more healthy.
Dr. Gray, did you want to say one more thing before we leave?
No, thank you very much thank you for allowing me to come and talk. I appreciate it.
Thank you, Dr. Gray. This was a very informative presentation. I'm seeing some of the comments and everyone is just saying great information. Thanks so much. No money on detox meds. Will do. I want to thank the panel members, as well as our guest presenter, Dr. Gray and Dr. Callender and Dr. Melanson. And thank you to our audience members for tuning in. We will be back with some more, another edition of Kidney Talks, Friday, April 8th at 2 p.m. We're going to be discussing living donation in honor of National Donate Life Month in April. Some great information to listen in, and you can stream and listen in after. So if you can't make it, it's okay. You can definitely tune in later. But this is Jennifer with the GW Ron and Joy Paul Kidney Center saying thanks, everyone. And we'll see you Friday, February 8th. Take care and be blessed.